Okay, well, good morning, everybody. My name is Carissa Chu. I'm from UCSF Urology, fifth year resident. Welcome to the second hour of our Urology Didactics today. It's my pleasure to introduce Dr. Sutherland from the University of Washington. She's the Director of Female Urology there. And she'll be talking to us about the AUA SUFU Guidelines 2019 on urinary incontinence, overactive bladder, urge and stress urinary incontinence. So without further ado, thank you very much for speaking with us today.
Great. Well, I think this is just a wonderful collaborative effort, and I'm just excited to be part of it, really. As said, I was asked to talk about urinary incontinence. I'm looking at the overactive bladder, urge incontinence, and stress incontinence, AUA and SUFU guidelines. And just so that those who don't know, the guidelines have been updated as of 2019. They came out before in 2017. Like many things are constantly being updated. So I will let you know what some of the more focused aspects of the 2019 guidelines are. Here's a list of my disclosures. So again, the outline, look at the evaluation and then the treatment per the AUA guidelines for overactive bladder, urge incontinence, and stress incontinence. This is a report that came out of the International Urogynecology Association and the International Continence Society looking at proper terminology for a variety of these female pelvic floor dysfunctions. So this is a good resource, and all of the terminology in this talk today comes from this. So urinary incontinence, of course, we're urologists. We know what that is. There are different types. These are the main ones that we see in women, and that's what this talk pertains to. Stress incontinence, of course, with any physical exertion or Valsalva. Urgency urinary incontinence associated with that urgency or that sudden compelling desire to urinate that's hard to defer. That's how they diagnose that or define that. Mixed incontinence is having both of those together. The vast majority of my patients have mixed incontinence, and teaching them to tease out what is happening when they leak and identifying was that a stress or urge is half the battle, really, because as you start treatment options, if it is not working overall for their incontinence, they think it's a failure, even though it might be happening for or helping for the urge incontinence and not helping the stress. And then continuous incontinence, of course, involuntary loss of leakage that's just constantly dripping, right? Helps us with a diagnostic thought process about what might be going on. Again, looking at OAB, it is a syndrome, and what that main aspect of that really is that there has to be a presence of bothersome urinary symptoms. So it has to be a self-report by the patient of urgency incontinence, frequency, and or nocturia, and in the absence of any other pathological thing that's going on that you think is irritating the bladder that could be causing those symptoms, of course. So frequency, we look at daytime frequency, we look at nighttime frequency, that which interrupts the sleep, right? So the getting up in the morning, first thing in the morning, doesn't count as getting up once because they're getting up anyway. And then 24 hours, of course. So what's normal? Usually we think of up to about 7 voids per day, and the waking hours is normal. But again, it's relative to the patient's perception, right? So how they perceive what's going on is what really matters. So the bother factor is really the key. If the woman's not complaining of it, you know, we can talk to her about what we could do to maybe improve some things if we think it's impeding her lifestyle. But if she doesn't think it's impeding, then we don't touch it. Again, we look at these symptoms as underneath this big umbrella of irritative voiding symptoms. And so we absolutely need to first rule out anything that could be irritating the bladder, causing these symptoms, so that we don't inadvertently just call it idiopathic overactive bladder and start her on our OAB pathway, right? What other things cause irritative voiding symptoms? Well, we know, of course, here's a big differential. Urinary tract infections, polydipsia, diabetes issues, right? Or even interstitial cystitis, painful bladder syndrome, people that have some pain component associated with these symptoms as well. So we need to make sure to rule these things out with our evaluation before we move on into just the simple treatment options. So here's the AUA-SUFU OAB clinical care pathway. I'm sure we're all familiar with this. Again, it was updated in 2019. The part I've highlighted here is just really the evaluation part, and we're going to go over that quickly. And then the rest of all of this is all about treatment. So just to point that out to you, makes it easier to look at that graph. So the first guideline statement, the clinician should engage in a diagnostic process. Well, what should that process actually require? There are 3 things that are mandatory, or the minimum requirements per the AUA guidelines: history, physical exam, and a focused physical exam involving the pelvic area, and then a UA. That's it. So any questions on your exams? That's it. History, physical, and UA for overactive bladder or urge incontinence. That's the mandatory requirement. So in the history, you know, the vast majority of the time, you can talk to the patient, you ask the right questions, and you know what's going on. And you do the rest of your evaluation, what you feel is necessary in order to confirm, as well as rule out anything else that might be a surprise. So you're asking these simple questions that are sort of listed here, looking at, do they have any difficulty emptying, hesitancy, what's their volume intake, so on and so forth. And again, what's the bother factor? You're also ruling out in your history any comorbid issues, right, that again could be contributing to the overactive bladder symptoms. See things like uncontrolled diabetes, recurrent UTIs, hematuria, of course, or do they have huge prolapse? They're coming in for urgency, urge incontinence, and if you don't ask the questions, you feel something bulging out there, you might totally miss that. And then if you don't go on to do a physical exam, which you should, but if you don't and just start some therapy, you may miss a big point. So moving on to the physical exam, this is from Campbell's, the focused pelvic exam. I like the way this is laid out because it really is sort of systematic the way you do it in clinic, with the exception of the digital rectal exam is listed here first. I would put that at the bottom of this list. You look at the pelvic exam, the external genitalia, then you're looking at the urethral meatus. Underneath the urethra, you're feeling for any lumps, bumps, diverticuli, getting in a little further to the bladder, feeling for any firmness or tenderness, looking at the whole vaginal area, what's the quality of the vaginal tissue, is there any prolapse, getting up further to see the cervix, and then doing the bimanual uterine as well as adnexa if you can feel. Then coming out, looking at the perineal area, the anus, closer look at that for hemorrhoids, and then a digital rectal exam. So the way this is laid out, it makes it easy to think about, what am I going to do when the woman's right there in front of me? I'm going to follow this kind of algorithm and make sure I touch all the bases that I'm supposed to be doing on the physical exam. So for other studies, supporting information, again, the UA is part of the mandatory evaluation. Why a UA? Well, there are 2 main reasons why we get a UA, right? What are we looking for? We're looking to rule out a urinary tract infection and rule out hematuria, right? If they do have hematuria by the guidelines, greater than 3 red blood cells per high-powered field, that warrants a proper urological evaluation, right? We're looking for other things that could be irritating the bladder. So what about a urine culture? Per the guidelines, and I think it makes practical sense, no. We should dispense with that automatic knee-jerk reaction of a UA-UC, sending it off all the time, because you should look at your UA and respond to the UA. If the UA is negative, it's negative. It does not warrant a UC. What about other diagnostic things? Per the guide statement number 2, again, culture, we just what are some other things? Another would be the post-void residual. Well, per the guidelines, it is not necessary in patients who are otherwise uncomplicated and who you were just going to start first-line therapy, so behavioral therapies, or even trying part of the second-line therapy, which would be overactive bladder medications. A post-void residual is recommended in anyone who has any kind of obstructive symptoms, or certainly any other complicated history. So in my practice, I find a post-void residual is very helpful almost in all patients. Not part of the guidelines. Again, it says it's not necessary if you have an uncomplicated patient. Maybe most of my patients are more complicated, but you see the patients who come in and their main complaint is, I'm not emptying my bladder. And you can prove they do empty their bladder. It's not an issue that the bladder can't get the urine out. It's a sensory issue, and the patient feels that they need to go to the bathroom frequently because of the overactive bladder symptoms. That's what makes them think they're not emptying their bladder. So doing a post-forward residual proves to them that they are emptying their bladder, if that's your suspicion, as well as if they're not, the treatment algorithm is completely different. We as urologists recognize that, right? And then the other supporting documents could be bladder diaries. If it is, it should be at least a 3-day diary. And I should say, I should have taken at least out of that sentence. The validated questionnaires and things show, or validated studies have shown, that 3 days certainly suffices. It shows the information that you need, and you don't get significant additional information if you do a 5 or a 7-day bladder diary, and it's much more cumbersome to the patient. But a 1 day, of course, does not suffice. So a 3-day diary is really where the money's at, and you need to look at volume in and volume out in order to really be that helpful. And then validated questionnaires can be helpful for those who still either can't figure it out, or it's good for really research purposes and looking at outcomes. Here's a bladder diary. We're familiar with what this is. Sometimes it really is a huge aha moment, not only for the provider, but also for the patient when they do that. And in this case, you can go through and you look, and the patient, BL stands for Bud Light, and you can see how many times there's a little bit of Bud Light going on, and she wonders why she's peeing so often, right? So it can be a little enlightening. So the third statement that's important, I put this as a question, but the statement, of course, is asking, saying, that in an uncomplicated patient, we don't really need to do a lot of other significant urological workups, such as urodynamics, cystoscopy, or any imaging. So the answer to this question really is no. It's not necessary in the otherwise uncomplicated patient. With everything that I just said, you should be able to figure out what's going on and go ahead and treat the patient. If the patients have some complicating factors, though, or are refractory to your initial treatment options or treatment attempts, then that puts them in a different category. Here are some things that make them complicated. Certainly our neurogenic bladder population, if they had prior surgeries, or again, failed some treatment options. So the choice of your testing is going to depend on, the history and physical that you do and your clinical judgment. So again, if they had prior incontinence surgery, that makes them a little more complicated. You might think about doing a cystoscopy. Do they have anything abnormal in the bladder that shouldn't be there from their prior surgery, whether it's mesh or even a stitch, and then a subsequent stone? Or are there more obstructive voiding symptoms that are there that don't pass the sniff test, so to speak, and you need to do a urodynamics to really see what their bladder function is. So certainly if they're having any outflow issues at all that are proven with an elevated post-forward residual, then I would get some type of emptying study. A urodynamics is helpful. So again, in summary of the overactive bladder part for the evaluation, the mandatory part of the evaluation is a history, a focused physical, and a UA. A PVR can be helpful. Fluid diary, again, if it's at least 3 days, volume in and out. And these other things, cystoscopy, urodynamics, imaging, are not indicated in the otherwise uncomplicated initial evaluation. If they are complicated, then think about doing some of these tests to help you make your diagnosis. And here again is the AUA-SUFU pathway, and you can see the history, physical, and other studies at the top for the evaluation. So the rest again is about treatment. So we're going to go into the treatment next for this. We can break it up into 3 parts: first line, second line, and third line therapies. You've heard those. What I will say is there is a 4th line therapy. It's actually always been there, but there's been not much focus on them. And that's why the newer guidelines in 2019 are really sort of bringing that back to light, to remind people that there is 4th line treatment, which we'll go into. So what differentiates this really is the first line is that there's no risk. They're behavioral therapies. There's no risk to the patient. Second line is it's not invasive, the options are there, but they do potentially have some side effects that impede or compromise the patient's quality of life. And the third line, now there are some risks associated that you need to talk to the patients about. So that's why they're classified as first, second, and third line therapies. Here's our guideline clinical pathway again. Here's the first line therapy, education, behavioral treatment, pharmacological management is our second line therapy, and then our third line therapies over here, which we're going to talk about. So in the first line, behavioral treatment, we won't spend a lot of time on this. I think most people understand this here. Education is key. Looking at their bladder diaries and doing some bladder retraining is very helpful. Pelvic floor muscle therapy, especially with urge suppression techniques, and then looking at fluid management and even weight loss can be helpful. If we look at second line therapies, one of the guideline statements says that the clinicians really should offer all patients oral antimuscarinics and or oral beta agonists. And it says specifically there in the guidelines, and we also know from FDA approval studies that in appreciable doses, there is no one standout in all of these types of medications that are available for the bladder. They all work about the same at appreciable doses. So that's what that yellow says. Here's the long laundry list of medications that are available that are anticholinergics and the beta-3 agonists. Again, there are some differences between them with respect to the severity of side effect profiles in the anticholinergics, and some that cross the blood-brain barrier and others that don't. But otherwise, with respect to efficacy, there's no standout. The guidelines, therefore, recommend, though, what I did say is there are short-acting and long-acting in some of the options there, and the guidelines specifically say that we should try extended release or long-acting therapy first, because we know that the side effect profile is actually more favorable with the long-acting formulary than it is with the short-acting. Now, I know many of us are always having to argue with the insurance companies, and we can't get it until they fail the short-acting first. And that's unfortunate, but the guidelines do say that we should be trying, when possible, the extended release formularies first. Then we also talk about if you have an inadequate response, rather than throwing it out, the baby with the bathwater, titrate the dose up and see how they do. If they have intolerable side effects, then switch to a different agent. And then the guidelines, what's new is they talk about combination therapy, especially with the advent of the beta-3 agonists now that don't have those typical anticholinergic side effects of dry mouth, constipation, that adding a beta-3 agonist to the anticholinergic may add efficacy, and some people have noted that in some reports, without additional side effects. So really looking at the addition of a combination therapy can be helpful before moving on. Again, the guidelines here, we have our first line, then our second line. And what happens if you've tried a number of those things there pretty diligently, the patient's been compliant and they're not successful or not adequately successful, they're not satisfied? We call that ROBI, or refractory overactive bladder. And those are the patients then that warrant further treatment options, which fall into our third line category. And that's what we're going to look at next. Falls into the tibial nerve stimulation, sacral nerve stimulation, or onabotulinum toxin. So the first one, tibial nerve stimulation. I think many people are familiar with this, but it is a 30-minute session. Looks like a little acupuncture needle goes right in by that posterior tibial nerve in the ankle. The patients are there for a 30-minute session once a week for 12 weeks. And at the end of the 12 weeks, they come back once a month in order to maintain whatever benefit that they've gained. By and large, most of the studies show that it really is helpful mostly for those patients that have mild to moderate symptoms. Patients that have severe incontinence, it doesn't really do that much for, but it really is a very low risk type of therapy. The only problem is that the patients have to come to the clinic. And that's really what's been a big deterrent, that the patients just can't get that into their lifestyle, of course. So what we have on the horizon, the next couple of slides shows where our future is going in the area of percutaneous tibial nerve stimulation, and it's therapies that patients can do at home by implanting a device in the ankle and let the patients do their therapies at home. This is no means advertising the next couple of slides, just to make you aware of what's new and what's out there. Blue Wind is one which the University of Washington, myself, is involved with in a multi-center trial looking at the efficacy of this, where they wear this little ankle bracelet. You implant the device, and then they wear the ankle bracelet in order to communicate with the device. This allows them to do more sessions, so looking at doing daily sessions rather than just once a week. And they've seen improvements in efficacy thus far. So that idea that it's only for mild to moderate patients may have been only because they could only do it once a week. If you can do it more often, maybe we can try to see if it'll work for more severe patients. Here are a couple other ones that are out there too that are being evaluated. So many of you at your institutions might have attendings that are involved in these, and these are also showing a lot of promise, and more studies are ongoing for these. Again, implantable devices that work similarly. Another device is a wearable vaginal device. I'm involved with this as well, have been for a couple of years at the University of Washington. And it is like a pessary, and it is meant to stimulate the inferior hypogastric plexus, again, for the treatment of overactive bladder. So hopefully we'll see more information on this with respect to its efficacy on the horizon. So now let's look at sacral nerve stimulation. We know it is modulates the voiding and the continence reflex pathways, working by afferent and efferent symptoms or systems. Its indications are not only for the overactive bladder urge incontinence, but also for non-obstructive urinary retention or Fowler's syndrome, as well as fecal incontinence. And its long-term efficacy has been well established repeatedly in the literature at this point. So what I talk to patients about with this is that the money is really, again, in how that lead gets placed, which is really my job. So I need to pick a patient that is going to be appropriate, that I think is a good candidate for this type of therapy, but then how well the therapy works is really how well I can get that lead placed. And the goal is to get the lead, as you can see in this picture here, if you can see my little arrows too, the lead is running along the length of the S3 nerve, and these are the 4 contact points. And if each one of those contact points is running along the length of the nerve, that allows them to be utilized for the therapy. We want to also see that we get good motor as well as sensory responses, that all 4 leads in at very low thresholds, less than 2 volts. With those parameters, you should have a good outcome. And here's what the implantable stimulator then looks like. So there's a newer one that's on the market today, and these are the 2 that are available, InterStim and Axonics, for sacral nerve stimulation today. The differences between them are, you can see the pictures here, the implantable generator that makes the thing work. This is what the InterStim one looks like. This is the Axonics. It's much smaller. And the other issue with the Axonics, that it addresses several needs, which the sacral nerve stimulation community has been talking about over a number of years, and that it is a rechargeable. So the battery life lasts for about 15 years, rather than with the InterStim, it lasts on average, we say, about 4 to 5 years, and has to be replaced surgically. As you can see, it's much smaller. It's also MRI compatible, so it doesn't have to be removed if the patient needs an MRI. It's current controlled, which theoretically the idea, rather than voltage controlled, would provide more consistent therapy, but we really need a head-to-head trial to prove that. And then the timed lead design, it makes it much more stable to resist migration. So there are advances with respect to what's happening with the Axonics device. With respect to the therapy, though, is delivering the same therapy to the same nerve, so the outcome should be the same. And then future directions for sacral nerve stimulation, this is called Nuspera, and it's using electromagnetic waves to power the implant. It's a tiny little implant. There it is. You can see compared to pills there, that's what gets implanted down by the S3 nerve, and then all the there's no implantable generator. The generator is external and communicate the device. We're involved in this too at the University of Washington to evaluate how well this is going to work for sacral nerve stimulation. And then the third therapy is botulinum toxin A. We can do this in the office. That's what makes it so nice. The starting dose by the FDA approval studies is 100 to 150 units, but we can go up to 300 units, especially in our neurogenic bladder populations when needed. The patients have to be willing to catheterize, or at least talk to them about the retention rate was 6%. But it was a short-lived retention rate, having to do intermittent catheterization for days, a few weeks afterwards. And so they have to be counseled that that is a possibility, but of course 6% is still pretty low. And then around the time of the therapy and the injection, getting a UTI is possible. We do use prophylactic antibiotics to try and decrease that UTI rate by the FDA approval studies again, the UTI rate was 13%, which is a little high. I think that's higher than what we generally see clinically, but we do need to talk to patients about this. It does work really quite well. They do have to have repeat injections. It lasts on average about 6 months. So they come in twice, maybe 3 times into the office in a year, and to have it repeated. So what's in the future of Botox? Well, there's now an intravesical Botox gel being investigated. So where you just put it into the bladder, much like a Urojet. There is a randomized control trial that's ongoing right now to look at the efficacy of this and how feasible would this be for patients to be able to do. Okay, so we have our first line, our second line, our third line. And as I said, if you get to the third line and they say they're still not doing well, we do have our fourth line, which is meant to be for rare cases, including urinary diversion or augmentation cystoplasty. The reason this is being put forward is that they found clinically many people are toggling between 1, 2, and 3 tiers and not even moving on to the 4th tier. Hopefully we don't have to move on very often, but people have sort of forgotten about it as a treatment option. And in the right patient, it really can be very, very helpful. So here, augmentation cystoplasty, again, the goals are to what? Increase the bladder capacity, of course, disrupt that coordinated detrusor contractions that are abnormal, causing that bladder to contract all the time, and then provide for a low pressure system. So how well does it work? Well, there are complications needing to do intermittent catheterization in the neurogenic detrusor overactivity, NDO. It's 60%, so it's higher than in the idiopathic, which would be stands to reason, right? The failure rate, surprisingly though, is higher in the idiopathic group. And if you think about it, maybe that's not so surprising, I shouldn't have said that word, is that in the idiopathic group, oftentimes there are multiple reasons why they're having their overactive bladder, urge incontinence, even pelvic floor issues, and doing an augmentation cystoplasty isn't going to fix their pelvic floor issues, as an example. So definitely there are other complications too that we know of when we use bowel in a place where it's not normally supposed to be, right? So metabolic disturbances, mucus, stone, and of course we have to be wary of the possibility of perforation in the future. So again, here is a summary for the overactive bladder clinical care pathway, first line, second line, third line, and fourth line therapies. And then a final slide for the overactive bladder evaluation and treatment. Just to put it in nicely, you have copies of these slides that, for you, but the evaluation, again, mandatory as history, focused pelvic physical exam, and a UA. Other additional things would be a fluid diary, postbard residual and symptom questionnaires, and the cysto or UDS for complex and refractory patients only. For treatment, then we have our first line behavioral, second line medications, third line forms of neuromodulation, and then fourth line is augmentation cystoplasty, urinary diversion. So with that, we're going to move on to the next category, which is about stress incontinence. These are the AUA SUFU stress incontinence guidelines. And in the first area, we have our evaluation, and then we have our treatment on the other side. So just to break that up easily. So let's look at the evaluation first. Again, stress incontinence, the loss of urine, okay, with the Valsalva maneuver, we know that it's very common. The etiology is usually thought of as threefold, although they can be crossover between these. The first is intrinsic sphincter deficiency. So it's loss of that intrinsic mucosal coaptation within the urethra, and it results in a very low Valsalva leak point pressure of less than 60. Or you can have urethral hypermobility, which is the loss of that hammock-like support under the urethra that's provided by the pubocervical fascia. And what we often see is a little bit of a higher Valsalva leak point pressure when it's associated with that, greater than 100. And then we have the integral theory, which is the loss of that ligamentous support, specifically the pubourethral ligament, that allows for this dynamic kinking phenomenon to happen to stop urine from leaking. So here I'm going to show you some pictures. The intrinsic sphincter deficiency. This is probably a familiar picture to many, and you can see here on the right side this nice coaptation. The mucosa is nice and plump, and over here that mucosa isn't so plump in the urethra, and you've got a wide open here where the urine just can come out. Here's where our estrogen also comes in handy, right? The local vaginal estrogen can help maintain the integrity of that vaginal mucosal, or the vaginal mucosa and the urethral mucosa, and that helps as well. Here's the urethral hypermobility. I think a picture says 1,000 words. You can see this pubocervical fascia here, and the hammock that's underneath the urethra, and at time of Valsalva, pushes down right against the urethra, and you can see it's closing the urethra. Here, if you have a tear in that pubocervical fascia, right, then you can see what happens. You lose on that Valsalva, you lose that backbone of support. And that's the whole idea here of the urethral hypermobility and recreating that support to try and improve that. And then the integral theory here, now we're talking about dynamic kinking that happens at the time of Valsalva because the pubourethral ligaments are keeping this stable at the level of the midurethra. And with the Valsalva pushing down on the bladder and the proximal urethra, and allows for this dynamic kinking so the urine can't come out. That's if you have a pubourethral ligament that is intact. And that's what the midurethral slings are meant to do. So we look at the evaluation for stress incontinence then. What's our mandatory parts? The history, of course, you got to find out, do they leak when they do a Valsalva? A focused physical exam, just like I already explained for overactive bladder, but this time it also includes a cough stress test of some type in order to document that the urine is coming out. I put Q-tip test down as not part of the mandatory part, and it's meant to assess for urethral hypermobility. You still read about it in some textbooks, but don't do it. It causes discomfort. Patients don't like it with that little Q-tip at the end of it. You can really eyeball to look for that urethral hypermobility, and if you have to, then if you're going to put a little catheter in, a female straight cath, because you're going to check for a post-void residual, then after you empty the bladder, have them cough and see if that actually moves, that catheter moves when they cough, and that can be your modified Q-tip test. The evaluation also requires a UA. Again, we're doing the same thing, rule out UTI and hematuria. But then there's one more thing that's involved, and now it is part of the mandatory evaluation for stress incontinence to do a post-void residual assessment to rule out retention. So you can see here, the evaluation is the same with the addition of, it's the same for the overactive bladder, with the addition of a cough stress test and post-void residual. So is urodynamics mandatory before doing any stress incontinence surgery? Well, traditionally the views have been yes, before we do anything invasive or some surgery that might have morbid consequences, but clinically many of us have given this up years and years ago, probably 15 years ago, but there was nothing in our literature really to support that, although, you know, what we were doing clinically until finally the value trial came out, and that showed that women that were already planning to get a sling, they had a positive cough stress test in the office, they had urethral hypermobility, they were then randomized to get a urodynamic test or not, and then they ultimately went on to get their sling, and it showed the urodynamics didn't change the plan, whether they're going to get a sling or not, and it didn't change their outcome. There was no difference in outcome between those who got a UDS and those who didn't, suggesting that no one learned any additional information from the UDS that caused them to change something about maybe how they tightened the sling or what they did. So we know there's really no added benefit in the otherwise straightforward index patient with stress incontinence that doesn't have any other complaints. Don't have to do a urodynamics. If you don't, they have urethral hypermobility, they emptied their bladder well, the UA is negative, and documented the cough stress test was positive in the office. So again, here's the AUA SUFU guidelines from 2017. It shows then, again, our initial evaluation. I didn't say about cystoscopy, of course. We don't need cystoscopy either unless you're suspecting that something else is going on or they're a more complicated patient. So now let's look at the treatment options. The treatments can be broken down into non-surgical and surgical, and then special cases below, which we'll touch on too. So non-surgical, observation, pelvic floor exercises, Kegels, continence pessaries, and now there are also vaginal inserts patients can buy actually over the counter. They're much like a tampon that just provide that support underneath the urethra as well. Those are the only options that there are. If they don't succeed with these, or they don't want to do a pessary or a vaginal insert, then your next recourse is really to move on to surgical options. Surgical options, per the AUA guidelines, bulking agents, mid-urethral slings, which are the retropubic and the trans obturators. They make a comment about the single incision slings, which I'll talk about in a minute. And then pubovaginal slings or fascial slings, which are bladder neck slings. And then the Birch copal suspension, which again is a bladder neck suspension. So I'm going to get that a little bit more in detail to differentiate that. So first, let's look at the bulking agents. So what's the rationale for them? Well, they cause coaptation in the urethra. They add a compressive force and thereby add resistance to the urethra by increasing the substance of that submucosal layer. We first used collagen, but found that that absorbs pretty quickly and you have to have reinjections. So permanent substances have been developed, or products have been developed, the Durus macroplastique and the coaptite. There is no standout in any of these. They each have their pluses and minuses with respect to ease of injection or so on and so forth. It really is in the provider's hands what they feel most comfortable with. The ideal candidate, though, for a bulking agent is really somebody who does have pretty significant intrinsic sphincter deficiency and no urethral hypermobility. If someone who has urethral hypermobility, then they really do, it justifies a trial of a mid-urethral sling or some other therapy like that. And I'll show you the data that supports that in a minute here. So the ideal candidate really for bulking agents, I strongly feel that it's those that have significant intrinsic sphincter deficiency, they've failed previous surgeries, they have this lead pipe urethra, and your only recourse is really to improve the integrity of that urethra somehow, and you do it with the bulking agent. So the bulking agent outcomes, 1/3 of them, review of the literature over and over and over again, you can see, and it shows that by and large, 1/3 of them maybe become dry, 1/3 somewhat improved, and 1/3 fail. So those aren't very good odds, 1/3, 1/3, 1/3, and that's why it's not really the first go-to agent. It often requires repeat injections, even the first encounter, meaning you do the injection, they don't get the outcome they wanted, you take them back to the OR or in the office if you're doing it in the office, and you top it off with a little bit more. But they also often require repeat injections as time goes on, and we see on average about every 1.5 years, they're coming back because they have recurrence and they want more injections. And there are complications. Many people view this as just do a bulking agent, it's super easy to do, there aren't really very many complications, it's easy. But there are complications, and I've seen some women devastated by repeat attempts at injection of this permanent material, and then also abscess formation. As you can see here, here's an abscess that formed around the urethra, and there's this black substance coming out, that's the durosphere. I did want to mention in the previous slide, just really quickly, I listed these 3 here. There is a new agent that's come out on the market. It's being used in Europe and having some really great success. And it's now been approved in the United States, so you might hear more about it. I don't know of therapists who are actually using it yet in the United States or using it successfully. It sort of came into the United States right before our COVID-19 hit, so no elective surgeries are happening. But after this disaster is over with, hopefully, we will probably hear a little bit more about it. The interesting aspect of the newer agent is not only the newer agent itself, the material, but also how it is placed. It's a different technique of injection, which provides for more reliable injection as far as location. So just to have mentioned that. Okay, so now let's look at our other surgical treatments. What we have on the AUA guidelines is a retropubic suspension, which is a Birch or a colpo suspension, if you've heard those terms. It is an abdominal surgery. Here's the picture of it over here, and you can see what they're doing is with your suture, grabbing some of this fascia that's next to the urethra, bladder neck area, and tying it up to Cooper's ligament to provide more support around the urethra at the time of Valsalva. The next category are slings and autologous fascial slings. Usually rectus fascia is used, but fascia lata as well. Here is a picture of harvesting the sling of the rectus fascia up above in the abdominal area or suprapubic area, and then down below in the vaginal area, placing that sling that now goes around the urethra, so underneath the urethra, thus the term sling, and pulls the sutures, proline sutures usually, up back up to the suprapubic area and ties over the rectus. And again, then causing this lift or support at the level of the bladder neck. The mid-urethral sling, however, is again something at the mid-urethra. It's meant to be no tension, not lifting anything up, and it's resting at the level of the mid-urethra. We have the retropubic, which you can see those pink arrows there. We have the Obturator going through the Obturator space here, and then the single incision sling is the same trajectory as the Obturator. It just stops at the inferior or the Obturator internus muscle rather than going all the way through that Obturator space. But the trajectory is meant to lie the same underneath the urethra for the most part in all three of those situations. This slide just really brings home the point, and I think this is so important, especially as urologists who are going to be doing work in this area, is the difference between a sling that's at the bladder neck and a sling that's at the mid-urethra, right? So bladder neck, again, you can see it placed there, and it's usually placed under a little bit of tension, and it's meant to hold that proximal urethra in place and bladder neck in place of the vulva. Whereas here, this is stabilizing the mid-urethral area, and so to allow for that dynamic kinking that's happening when the patient does have urethral hypermobility. So both of these really work well in a patient that has urethral hypermobility. If they have no urethral hypermobility, this isn't going to work, the mid-urethral sling, right? Over here, no urethral hypermobility and lead pipe urethra, then a bladder neck sling can be helpful if it's placed under a little bit of tension. And it's really stabilizing the bladder neck where it is. So that's the main difference. So when you read the literature and they talk about slings, today it's a little bit better. People are more specific about what they're looking at. But in the past, they used to lump slings, and you'd find they were doing retropubic slings. They were doing a pubovaginal, as well as mid-urethral, all lumped in together. So our choice of surgery, those three that are mentioned because they've been historically considered gold standards. And why are they considered as gold standards? Because in the literature, there's some long-term data that exists, long-term being defined as greater than 5 years. However, so that's the Birch, the autologous sling, and then also the retropubic synthetic mid-urethral sling, right? So the two bladder neck procedures and the mid-urethral sling. However, even though it has 5-year data, let's look at that data. This is one of the best studies looking at the difference between Birch versus an autologous sling called the SISTER study. It was reported in 2007 in the New England Journal of Medicine. And it was a randomized control trial that looked at the difference between those two with respect to objective and subjective outcomes at 2 years, and then the extended trial took it out to 5 years. And what you can see right there, the autologous fascial sling at 2 years, the subjective success rate, 66%. Compared to the Birch, 49%. That's pretty bad, I think. At 2 years, you're going to tell your patient at 2 years, this is how good you'll be. And then when they looked out at 5 years further, it was 31 versus 24%. So a lot of dissatisfied patients after this procedure. The Birch, again, keep in mind, is an open abdominal procedure. The autologous sling, although it's not open abdominal, you're still harvesting something at the rectus fascia and then also going below. The autologous sling was associated with a little bit more in the way of avoiding dysfunction because it was put under a little bit more tension, and then UTIs, but that wasn't that significant. When we look at the midurethral slings, one of the most well-known studies and well-done studies was the Thomas trial, looking at the TVT versus the TOT, so the retropubic versus the transobturator, and looked at outcomes only at 12 months on this one. But what they found ultimately was there were similar objective and subjective outcomes between the two. So meaning that either one of those could be a good clinical choice for you. If you looked at the objective cure rates between the two, 81% versus 78%, and subjective cure rates, 62 versus 55 or 56%. So the subjective cure rates do often fall below the objective cure rates, although this subjective cure rates in this study really are much lower than what has also was reported previously as well as subsequently in our literature. We have much higher subjective cure rates. So it could be by just the way they were looking at those subjective cure rates. In the objective, they looked at a negative cough stress test, negative pad weight test, and no retreatment. So that's pretty stringent. And the subjective was just self-reports of no leaks whatsoever. So there could be some, mixed incontinence in there, looking at the bladder diary and then no retreatment. All in all, though, they showed a little bit higher voiding dysfunction in the TVT, the retropubic group, 3% almost versus nothing in the transobturator, and then more neurological symptoms and pain issues in the groin on the transobturator compared to the TVT group. But again, no difference in postoperative urgency, incontinence, satisfaction, or quality of life between the two groups, showing that they are comparable with respect to efficacy and certainly safety. But if we look in the retropubic group, of course, it's been around the longest, first FDA approved, I think in 1996 or so. And so we have good long-term data. Here we have 17-year prospective data on this first group of women that were looked at with the TVT, 3 centers, and we have 78% of those patients had a follow-up of a median of 17 years. So that's pretty good. It's not just that half of the patients we have follow-up on. And what we saw really was the 81%, oops, sorry about that, 81% objective cure rate. All right, so what we're going to say is, what about the single incision slings then? Well, the guidelines for stress incontinence are out at 2017, so that's already 3 years ago. And at the time, they said there's lack of long-term data in order to support the single incision slings, but there was long-term data for the full-length transobturator and retropubic slings. Didn't say that you couldn't use the single incision slings or they wouldn't recommend it, but that you need to be sure, full disclosure to the patients, that there's not a lot of long-term data that's there. But in 2019, there still didn't add anything additional, but what we do know, because the guidelines came out since this study, there's now a SOLEX study, the 522 FDA mandated study, which was out to 3 years and shows good efficacy and safety. These were composite success outcomes, objective and subjective criteria, looking at the SOLEX, which is the single incision sling, at 90%, compared to the transobturator at 88, 89%. So basically the same. And this was a randomized control trial that was done. So we do have data now that goes out 3 years, and even some others that are going out 5 years to support the use of the single incision sling in the otherwise uncomplicated patient. Can you move the slide? Yeah, okay. So there are complications, of course. Here's a list of the complications. Go back one slide, please. Can you go back one slide to the complications? Yeah. So what I want to point out there is on the complications that all of those things, except for that which is highlighted in yellow, are associated with patients with any type of anti-incontinence surgery, no matter what you choose. And if you look at those, you'll see that's absolutely true, right? The only things that are associated with a mesh surgery are things that involve the mesh, extrusion into the vagina, perforating the urethra or the bladder. Those are mishaps that if they happen, they should be recognized at the time of surgery and then corrected. These complications can only, oh, you said that. Okay. Sorry, I'm trying to do it on mine as well. All right, if you go to the next one. So we know today, and in 2017 on the guideline, 2019, and even as back as early as 2014 by the American Urogynecology Society and Society of Urodynamics, Female Urology,
The mid-urethral sling is standard of care surgical treatment of stress incontinence. And the hubbub there with the mesh litigation, due to its very favorable risk profile compared to the benefit ratios. So it really is the standard of care, and still today in 2020, it's the most common procedure done worldwide for stress incontinence. So the next slide shows the whole algorithm again for stress incontinence, showing the treatment evaluation on your left side and on the right side the treatment. And the last category are these special cases. So if you go down to the next slide, just real quickly, the special cases are those where we have to have a little more thought, right? And as urologists, we think, okay, they've had prior surgery, they've had lots of things going on, they now have a fixed immobile urethra. Well, if it's immobile, the mid-urethral slings really aren't going to work well. So, but what does work still is something that happens at the bladder neck, right? So we already said for bulking agents, pubovaginal sling can come in nicely if it's done at the bladder neck and then underneath a little bit of tension. And some people have advocated retropubic mid-urethral slings, but then placing it somewhat at the bladder neck, which is really almost a little bit off-label, but will also work. But the caveat there is you have to be careful how much tension you put it on. If you think you have to put it on significant tension because their urethra is so immobile, you're better off with a fascial sling. Doing concomitant prolapse surgery, they say any incontinence procedure is possible, but really most people would say if they have urethral hypermobility, doing it in a mid-urethral sling is really what should happen. The third category, you have any concomitant neurogenic bladder issues. Well, we're going to look at them as a neurogenic patient and do our evaluation appropriately and try to see, is it really what's in their best interest? Most often in neurogenic bladder patients, you're having to do something under a little bit more tension, and then you're going to look at a fascial sling at the bladder neck. And then the last category, of course, keeping in mind those childbearing patients or maybe other special cases like geriatric and obese. You're going to take them one at a time. Certainly the caveat as well with a mesh procedure is identifying to the patient that they are permanent materials. But in that, having said that, when we use permanent materials with our pubovaginal slings as well, if we use Proline, we should be disclosing that to the patients too. All right, next slide. So the next two slides are just, again, a summary just to put it all together for you. Is the evaluation is history, physical, focused pelvic, cough stress test, a UA, and a PVR is what's mandatory. A fluid diary and symptom questionnaire can be helpful. The other things, cysto-UDS imaging for complex patients only. And our treatment options are non-surgical, right? Either Kegels or something that's going to help support it, like a continence pessary, and surgical, bulking agents. And then I put underneath there our gold standard procedures with our subjective successes at 2 years and then at 17 years. So you can make those comparisons when people are using those terms, standard, and saying that the Birch or the pubovaginal sling is still the gold standard, but compared to what? And I just showed you the data if you want to look at comparisons. These are the subjective successes at the 2 and 17 years. So next slide is just a little humor slide. So people to ponder and my thank you. And then the last slide, give you the opportunity to give feedback today about this this lecture. You could take this survey. Also, please use social media, #Urology COVID, or look at the website for urologycovid.ucs.edu. So thank you. Yeah, I'm happy to take questions. Sorry about that little glitch there. Don't know what happened.
Thank you so much. Thank you so much, Dr. Sutherland. That was a great review of a big topic and a lot of patients we treat and certainly very testable. So thank you very much. I'm going to try to sneak maybe 1 or 2 questions in here. We got a couple about, has the new data on the use of anticholinergics and the links with dementia and elderly patients, has that played into your practice at all?
Absolutely. So that's where some of the recommendations too for the guidelines change to think about the combination therapy, so that if you do feel you're using an anticholinergic, you're using it at a smaller dose, and then maybe increasing the efficacy with the combination therapy of the beta agonist. Or the other two, we don't have time to go into all the detail, but the other anticholinergic medication that does not cross the blood-brain barrier is trospium or Sanctura. In the short-acting or the long-acting formulary, it doesn't matter. It's a tertiary or a quaternary amine, is the chemical compound. So it doesn't cross the blood-brain barrier, so it can't cause cognitive, mishaps. But all of the others do cross the blood-brain barrier. Of course, the beta agonist does not cross the blood-brain barrier. So if you're concerned about that, we're seeing increased use of both of those. And I don't understand the rhymes or reason. It's all negotiations and has to do with money between the insurance companies and the pharmaceutical industry. But we're seeing some where Myrbetriq is first line. And I'm so surprised to see that now. But I think some of that came from a push because of this dementia issue.
Perfect.
Yeah, good question.
That was a great question. So what else do we have? So there's also a question about whether Valsalva leak point pressure should play into your sling of choice. A lot of these patients, don't have urodynamics. For straightforward stress urinary incontinence, it's not necessarily indicated. But does that kind of play into your thinking about what type of sling you might select?
So we're talking about what type of sling between a retropubic, what type of sling, bladder neck versus midurethral versus what type of midurethral sling. So those are two different thought processes there. But first and foremost, what I will tell you is I put those Valsalva leak point pressures there because they're often nice little test questions. Clinically, I think it's really hard to use the Valsalva leak point pressures. If anybody who's had some experience doing urodynamics and trying to look and see what is the exact Valsalva leak point pressure and seeing a reproducible answer throughout the same test, it's crazy, right? And so how can we say 60 is less than 60 is intrinsic sphincter deficiency, but if they have 80, they don't, or if they have 100, they have urethral hypermobility, but then if they have 120, do they have any ISD? No, we can't really say that. So there's some guidelines that came out from, some helpful hints, I guess, to use from some studies that have been done so long ago, and we still see those numbers and but what we really think about is if they have a low leak point pressure, think about there's more than just urethral mobility probably going on. Because many of these patients have urethral mobility and intrinsic sphincter deficiency. We don't think of it as an either or, but more of a continuum, right? Of both of those problems happening, but how much urethral hypermobility versus how much intrinsic sphincter deficiency in one patient. So if they have a really low intrinsic sphincter or really low leak point pressure, think about, do I need to do something a little different? Maybe. I think if they have a lot of urethral hypermobility, they're a good candidate for a sling regardless, and that urethral hypermobility is going to make sling work. If it's a severe case, I'm going to be really, really careful about how I tension that to get it right up there on the urethra without being obstructing. The other aspect of that is I think what you would see clinically and maybe, academically, that if they have really high leak point pressures, if they have really low pressures and a lot of intrinsic deficiency, there's more data to support maybe thinking about doing a retropubic or a pubovaginal sling. So in other words, having the money be a little at the bladder neck, right? The action.
That sounds good. Unfortunately, we are at 11:13 already, so we'll get the rest of your questions answered on the website. Thank you again so much for your time, Dr. Sutherland. It was
okay. Yeah. Thank you for having me be part. It was a
thank you so much.
Pleasure.
Take care, everybody.
Okay.
Have a great rest of the day.
All right. Thanks.